Welcome to this EURO-NMD webinar organized in collaboration with the European Reference Network for Rare Neurological Disorders and the European Academy of Neurology. Today, we are presenting one of the webinars in the series of webinars from the Neuromuscular Junction Working Group. In fact, it's the chairman of the working group, or one of the co-chairmen that is presenting today, Hans Lochmüller, that is a renowned clinician and scientist specialized in neuromuscular disorders, with a focus on uncovering the genetic causes of these diseases, understanding the molecular mechanisms, and developing targeted therapies through an integrated multi-omics approach, including combining genomics, molecular biology, disease modeling, and clinical trials. So Hans has had a major role in many international research and networking initiatives, including the EuroBiobank, the Treat-NMD Alliance, the RD Connect, and the Interdisciplinary Science Committee. As I said, he co-chairs the European Reference Network for Neuromuscular Disorders Working Group for Neuromuscular Junction, and is a professor of neurology at the University of Freiburg in Germany, and the CHEO Research Institute in Ottawa in Canada. Is also the founding co-editor-in-chief of the Journal of Neuromuscular Diseases, and serves on numerous international advisory and oversight boards. Has published over 450 peer-reviewed articles and continues to mentor students and researchers interested in advancing neuromuscular science. So, Hans, I just have to thank you for your kind participation and pass you the floor to you.
Yeah, thanks so much, Antonio. And it's a pleasure to talk today about congenital myasthenic syndromes. So this is one of the key areas that my clinical and scientific research is in. And I have both patients in clinic with this condition. I get a lot of referrals from many of you, and I also have a research team in the lab that uses models to investigate congenital myasthenic syndromes. And it's part of the series on myasthenia gravis, and I think you had a few excellent talks about myasthenia gravis already, and I try in the coming 40 minutes or so to cover the genetic forms of myasthenia, or we call it currently congenital myasthenic syndromes. There's a bit of a push towards giving this condition another name. The reason is that not all forms of this condition actually start at birth or truly congenital. Some of them start later in childhood, or some even in adulthood. So even for adult neurologists, this is a relevant topic. I have some disclosures because I do a few trials, including a trial that I will mention later in my talk, and that trial is sponsored by Argenx, so be aware of that conflict of interest. So I will talk primarily on how to diagnose and treat congenital myasthenic syndromes, and I will go a little bit into how we investigate neuromuscular transmission disorders in model systems. But the main part of the talk today is really clinical. So I show you that video that my colleagues from Barcelona kindly gave me a few years ago. And you see in the video that this girl can walk on the flat. She has ptosis. Her mouth stands open. She has slightly winged scapulae, and her knees and feet are a bit inward rotated when she's walking. She's now being asked to sit down on the floor, which she does. and then asked to stand up from the floor, and there she's struggling, so she needs to push herself up with her arms on her thighs. So it's a typical Gowers maneuver that indicates proximal weakness. She walks over again. You see the feet and knee inward rotated, and now she's asked to lift her arms, and that's quite difficult for her. And if she's asked to do this again, then it becomes almost impossible. So there is a clear indication of proximal weakness that is fatigable. And on top of that, you also seen the ptosis and some fatigable weakness in the face. So that indicates a congenital myasthenic syndrome, which is the topic of the day. What you may have not seen, because that wasn't actually checked in this video, is two things that I should also mention. The eye movements in this child are completely normal. So that's an important distinguishing syndrome that I will talk about later. And if she is being asked to walk stairs, then that's something that she cannot do at this point. So she's completely unable to walk stairs, which obviously brings some disability in everyday life for this girl. So other examples of patients with congenital myasthenic syndromes are on this slide. So all these patients have been diagnosed with congenital myasthenia through a genetic test in the end. But the presenting features may be actually quite different from patient to patient. So that ranges from floppy infants with arthrogryposis, where maybe the first thought would be, could this be SMA, to adults with ptosis and ophthalmoplegia, where maybe the differential diagnosis is a mitochondrial condition, to people who are wheelchair-bound and have atrophy, scoliosis, or respiratory distress, like the two patients on the right, where you first thought is this a muscular dystrophy? So there's a fairly wide range of presentations in congenital myasthenic syndromes, and therefore they often get misdiagnosed or not diagnosed. And because it's, as I will show you later, a condition that is often treatable, it's very important to come to this diagnosis. So how do we do this? The first is the clinical suspicion. So if there's more fluctuation than you would expect for a myopathy or neuropathy, if there's not only downs but also ups, then that's a point where you should suspect congenital myasthenia. And these ups and downs in the severity or in the presentation may not only be within a day or from day to day, they may sometimes last weeks or months. So children that may at times be able to go to school and be reasonably well, maybe just a week later on the intensive care unit on a ventilator and not being able to move much at all, and then recover from that. So this is not something that you expect from a standard myopathy. Clinical neurophysiology is really helpful in this case. So like you see in the upper right image, if you do a repetitive stimulation, you often see a decrement. There are some patients with some of the genotypes that don't regularly show a decrement. So absence of a decrement does not exclude congenital myasthenia, but if you find it, it's a really important pointer. The mainstay of diagnosis nowadays is really molecular genetic testing, and we believe that we currently can genetically diagnose about 70 to 80% of all patients with congenital myasthenia, which is a considerably higher rate than for some other neuromuscular conditions. Because it's not autoimmune, and in the differential diagnosis, importantly, we don't find acetylcholine receptor or MuSK antibodies. So there's always the question, is in that group of seronegative patients, are there some patients with congenital myasthenia? And a recent publication by our Austrian colleagues actually indicates that there's a few patients to be found. There is often, but not always, a positive response to esterase inhibitors, which you then can use as a diagnostic sign. However, if patients do not respond to esterase inhibitors, that does not exclude congenital myasthenia. There are certain forms that we will come to that definitely do not respond or even get worse with esterase inhibitors. If you need to do a conventional muscle biopsy to distinguish from other forms of myopathy, for instance, then what you see in congenital myasthenia is like the two tissue images on the right-hand side. It's a relatively mild tissue pattern with maybe some rounding of fibers, maybe a few internalized nuclei, but certainly not a severe dystrophic process. So maybe this is another touch point where if you expect, based on the clinical severity of the patient, someone who's got lost ambulation or has breathing difficulty, and you expect a severe dystrophy on the biopsy, comes back from the pathologist saying, well, there's not much wrong with this muscle, at most an unspecific mild myopathy, then I guess that's another point where you should start thinking maybe this is not a muscle condition, maybe this is neuromuscular transmission, and then do some of the other tests that I mentioned. Currently, we know about 35 different genes that can cause congenital myasthenia, and that number has increased over the years, and some of the genes were discovered in my lab. I'm not going to describe all of them because that will become very boring, and some of these genes are also very, very rare, so it's very unlikely that you come across them. So I will only touch a few highlights of them. However, what I want to say is that they can roughly be divided up into presynaptic, synaptic, and postsynaptic genes. And the majority of patients that we currently diagnose have postsynaptic CMS. Presynaptic are less common. Secondly, what I want to highlight is that the vast majority of patients with congenital myasthenia are autosomal recessive, meaning that both copies of the gene need to be affected by a pathogenic variant, and therefore most of the time patients are just affected in one generation. So parents are not affected and their children are not affected either, which then particularly for small families brings up the question, well, is that actually a genetic condition, or is it sporadic, or is it acquired, whatever. So think about congenital myasthenia primarily as a autosomal recessive condition. There's a few exceptions, so-called slow channels, or the SUT2 gene that have a few dominant variants where you find several generations affected, but that's only about 5% of all patients with congenital myasthenia. The other thing that I want to highlight in this scheme is that it's not, unfortunately, not as easy to say, well, postsynaptic patients would sort of respond to mestinon and the presynaptic ones get 3,4-diaminopyridine. It's actually much more complicated. And the reason for that is that one needs to really understand what the exact pathogenesis is of a particular gene to understand whether a drug treatment works or not. So I'll just describe briefly the three most common phenotypes in, at least for European patients. It's a little different from different geographies, and certainly you would find a slightly different distribution in Asia or South America or other countries. But in general, recessive mutations of the epsilon subunit are the most common forms of congenital myasthenia, making up to like 30 or 40% of all cases. And very typically, these patients start having symptoms early in life, within the first year, and they usually would have ptosis and fixed ophthalmoparesis. So this is an important sign in these patients. If you ask them, is there something wrong with your eyes? They say no, or they say, well, my eyelids are hanging, but they won't report on double vision because they usually do not experience double vision. But if you test them by asking them, follow with your eyes my finger or my reflex hammer, then they can only follow by moving their head. They would not be able to move their eyes at all. So fixed ophthalmoparesis is a very important sign in these receptor deficiency patients. they would usually respond fairly well to esterase inhibitors up to relatively high doses. So a standard dose is between 5 to 10 milligrams per kilogram per day. And sometimes we add on a second medication to give more benefit, and that could be 3,4-D-immunopyridine or more recently salbutamol. Everything that I say here about therapies, in fact, is off-label, so be aware of that. A second form of congenital myasthenia looks quite different phenotypically. So if you look at these patients, there's no ptosis. And if you look at the girl, she can actually move her eyes quite well. So these patients would experience primarily limb girdle weakness. And in those patients, occasionally you find so-called tubular aggregates that are indicated by the yellow arrows in the muscle biopsy in the NADH stain. So this is a form where the GFPT1, a glycosylation gene, is affected, and that causes congenital myasthenia that is also responsive to esterase inhibitors. In contrast, there's a second form of limb girdle myasthenia, which is not responsive to esterase inhibitors, and whereby the patients have similar symptoms with proximal weakness. In fact, the girl that you saw in the first video has that form. And these patients do often experience worsening and improvement, not from day to day, but over weeks and months. And they do not respond well to mestinon. They do actually get worse at times. So they come off mestinon quite quickly if you try it. And these patients usually have mutations in the DOX7 gene. And we'll come back to the DOX7 gene in a little bit more detail later on. So these are three major forms, and I'm not going into detail for some of the other genes, but I'm happy to answer questions about patients that have mutations in other genes in the question period at the end of my talk. So what we do we do therapeutically? On the right-hand side of this diagram that was given to me by Dr. Rodriguez, there are the patients that would respond to pyridostigmine. So it's primarily the receptor deficiency patients, but also patients with defects in rhabsin, in some of the glycosylation genes or in chat. And then there could be the add-on. Currently, we are obviously moving a little bit more towards salbutamol as a second, as an add-on therapy. And then there's the patients that do clearly not respond well to pyridostigmine, where you should avoid pyridostigmine. And these are the DOX7 patients that I mentioned, but also patients that have defects in CoQ or slow channel syndrome patients. And for those patients, the first line of treatment might be salbutamol, or for the slow channel, fluoxetine. I have to warn that one shouldn't just indiscriminately go to fluoxetine if mestinon doesn't work for a patient with congenital myasthenia, because fluoxetine can actually make most patients with congenital myasthenia worse. And that's because it's a channel blocker. So it really should be reserved for patients with a confirmed slow channel mutation. So this is the same girl again. Now it's a couple years later. She was diagnosed with DOX7 congenital myasthenia, and she's been given now salbutamol for about a year. And she's now able to stand up from the floor quite easily without a gouge, and she's also able to lift her arms. So also her face is very different from what you've seen before. And here she's asked to walk up the stairs, something that she couldn't do when the first video was shot. And while she's not running up the stairs like other kids her age would do, she holds on quickly to the railing, and then she's actually walking up the stairs slowly, which she was unable to do before she got the treatment. So therefore, while drugs like salbutamol or mestinon do not obviously cure the condition or correct the gene, they bring a good degree of symptomatic improvement for many of these children and also adults. So I'm coming now to a few cases where we ourselves were scratching our head. Is this congenital myasthenia, or are we missing something, or turning it the other way around? How far do we sort of stretch that definition of congenital myasthenia? Obviously, the classical ones there that I've shown you, they were all postsynaptic, so there was little question about it, even for the glycosylation defect. But here in these two brothers from India, in addition to their fatigable weakness and their ptosis and their eye muscle involvement, they did also show a slight degree of intellectual disability and some seizures, which sort of indicated potential central nervous involvement. And that's something that we see more often in presynaptic CMS, because of course the neuronal changes could also affect neurons in the brain. So we did feel, and Dr. Nalini in India, who saw these patients, was actually quite convinced that they have congenital myasthenia, also based on the decrement that she found in both of these brothers. However, with standard sequencing in a panel of genes, the underlying genetic defect was not elucidated in these brothers. So we did some more testing, and first of all, there was a surprise in the muscle biopsy, because that muscle biopsy showed clear mitochondrial changes with COX negative fibers and SDH hyperreactive fibers, and a complex 1 in 4 defect of the respiratory chain. And once we done a whole exome sequencing in this family, we identified a homozygous variant in a gene that was not known to cause disease at this point, the TFM gene, which is a mitochondrial gene, an elongation factor. So we wondered, is that really the gene that causes the neuromuscular transmission defect that we had detected in these patients? So we went to one of our animal models that we use to understand better whether certain mutations or genes are involved in neuromuscular transmission and could cause congenital myasthenia, and that's the zebrafish embryo. So injecting the zebrafish embryo shortly after fertilization with an antisense molecule that knocks down the gene lets us observe phenotypes as soon as like 2 to 5 days after fertilization. So it's a very quick readout in these animal models, and you can observe lots of them in one go. So what we found is that their neuromuscular junctions were disrupted if we knock down the TFM gene, and this is depicted in the lower panel, where green shows the nerve and red shows the acetylcholine receptors, and the overlay on the left-hand side in yellow, that's nice neuromuscular junctions in the upper panel, which is the control, and disrupted in the lower panel with the knockdown for TFM. And when we observed these zebrafish embryos at 5 days after fertilization, how they move around, and zebrafish move around more if the light's turned off than if the light's turned on, then we clearly see a defect in movement that's fatigable in these zebrafish embryos. The knockdowns are indicated in red and the controls are indicated in blue. So we've basically proven that this gene can cause a neuromuscular junction defect, and more work was done to figure out what exactly is the pathophysiology. Is published now by Dr. Horwitz and Dr. Minczuk's labs. And there's additional patients now identified that have more severe mutations in this gene, that have a more classical mitochondrial phenotype, where maybe this neuromuscular transmission defect is not as obvious. But at least in this family, it was a primarily neuromuscular transmission defect, very reminiscent of congenital myasthenia. Come to another case. Again, question of differential diagnosis and overlap syndromes. So this patient, as well as several others from the same region, do have fatigable weakness, but they also show permanent weakness. And in fact, in a biopsy, this doesn't look like congenital myasthenia anymore. As I told you before, that congenital myasthenia has a very mild tissue pattern with just some rounded fibers. So this is clearly more going on here with some degenerating fibers, some very small and some larger fibers, and some inclusions as well and irregularities. So it turns out that these patients have recessive desminopathy, in this case, a recurrent splice site mutation. And this does not just lead to a myopathy like the dominant desmin mutations, but also to a clear neuromuscular transmission defect with a decrement and partially responsive to esterase inhibitors. And the final case of how far this overlap can go in some points. So this was a young person from Brazil referred to us, and again, he was showing up at a neuromuscular center for looking at his fatigable weakness. And there were also some minor facial dysmorphism noted, as well as some intellectual disability. But still, the thing that brought this young man to see a doctor was his fatigable weakness. And again, we excluded all the CMS genes that were known at this time. And then by whole exome sequencing, we found a mutation in a Noonan gene, which is actually a known and fairly common pathogenic Noonan mutation. So even in some patients with more neurodevelopmental disorders, there can be not only hypotonia, which is quite frequent in these patients, but also clinically at least fatigable weakness as a consideration. So I summarize these sort of which I would call CMS plus forms or differential diagnosis of CMS. So if you have a very high CK, which is something that's usually not found in most other forms of CMS, then think about recessive desmin, GMPPB or Blactin. If you have mitochondrial pathology, it's the TFM gene, as I showed you, but also the SLC25A1 gene. So we do think that mitochondria are quite important at neuromuscular transmission, and we even framed a new form of CMS, a mitochondrial CMS that has these two genes so far. There's overlap with, of course, congenital myopathies of different genotypes, overlap with a motor neuropathy for the dominant SUT2. I showed you the Noonan case, and then overlap with the congenital disorders of glycosylation. I showed you GFPD1, but there's of course also ALG2, ALG14, and DPHGT1. So there's a whole group of N-glycosylation genes primarily that can cause both congenital myasthenia as well as more severe CDG or anything in between. So switch gears now, and I'll come to some of the new therapeutic developments. So I've talked about mestinon and salbutamol, and we can discuss why salbutamol works, etc. So it's a long-standing question. But before we go there, I want to explain in a little bit more detail some of the pathways and molecules that act at the neuromuscular junction. So of course, there's this main pathway whereby the neuron secretes acetylcholine, and that gets across the synaptic cleft, meets the acetylcholine receptor, and that then opens and causes the current, etc. But there's a second signaling system where the nerve talks to the muscle, and this is the so-called agrin-LRP-MuSK pathway. So agrin is secreted from the nerve terminal, and then it does find a heterodimeric receptor, which is the muscle-specific kinase and LRP4. So MuSK is that blue molecule, and LRP4 is that one that sticks out a little bit further. So activate that cartoon. So agonist is coming in, binds to this MuSK-LRP4 receptor. Then that changes its conformation. That leads to phosphorylation of the intracellular domain of MuSK. That recruits DOX7, so that molecule that I mentioned before as cause of one of the limb-girdle myasthenias. DOX7 gets phosphorylated and activated as well. And that leads to intracellular signals that then activate the acetylcholine receptors and lead to clustering. So this whole pathway is responsible both for building the neuromuscular junctions in development, but also maintaining them. And if any molecule in this axis is defect, and obviously we've been talking about DOX7, then this activation doesn't work, and therefore the maintenance of the neuromuscular synapse isn't there. So just to illustrate that MuSK phosphorylation or activation of MuSK is sort of a key aspect of neuromuscular transmission. And based on this understanding, of course, people have trialed, at least in mice so far, gene therapy replacing DOX7 through an AAV, bringing DOX7 in. But there's another method to actually replace not DOX7 itself, but maybe replace the function of DOX7. And this was first developed by a researcher in New York, Steve Burden, and has now been taken on into a translational pathway, including clinical trials sponsored by the company Argenx that I mentioned in the beginning. So in this cartoon, you again see the MuSK-LRP4 receptor and the stimulation by agrin. And the invention that sort of comes in here in the absence of DOX7, which you see on the right-hand side under 5, an antibody is used to actually cross-link the two MuSK-LRP4 receptors and help with the activation and phosphorylation of MuSK in the absence of DOX7. So the treatment that's being proposed is not a gene therapy, it's an antibody treatment, but an antibody that's not immunologically active, like in autoimmune disease, an antibody that purely binds to that extracellular frizzle domain of MuSK, cross-links it and activates MuSK. So that's also why they're called MuSK activators. If you do this in DOX7 mice, then you actually see a stunning effect. So DOX7 mice that carry the same mutations as DOX7, many of the DOX7 patients actually do very poorly and die about a week after birth. These are the control mice here indicated with this green arrow. So if you give them the MuSK agonist antibody at birth, then they do not only survive, but they also grow and they move around in the cage like they're healthy litter mates. And that lasts for about 65 or so days. By that time, then they would lose weight again, and they would not do as well. And if they redosed at this point with the same antibody, then they pick up again. So it is obviously not a therapy that lasts forever, at least in the mouse. It sort of lasts for apparently about 2 months if it's given right at birth for these mice, and then they need to be redosed. So this has gone now into a first clinical trial, a 1B trial of only 16 patients, of which 13 received the MuSK agonist antibody and 3 received placebo. They received this every 2 weeks in escalating doses, so starting with the lowest dose, and then going up from the 4th infusion for a total of 3 infusions with the highest dose. And we were interested in this trial, of course, whether this new treatment, which had at that point only been tested in healthy volunteers, would be safe, but also, of course, if there would be some early signs of efficacy in these patients. There were only patients included, of course, that had DOX7 congenital myasthenia, and they were relatively severe, so they had to have at least a score of 2 in 3 out of the 5 key components of the QMG, meaning that they had to have usually quite severe fatigable weakness in arms, legs, or neck, which are obviously some of the key symptoms of congenital myasthenia. These tests were not frequently done in patients with congenital myasthenia. At this point, there was basically a run-in natural history study that informed us about some of these parameters. And this was done in a multinational, multi-center study, including our site in Ottawa. So the 2 patient groups were relatively well matched, even so the placebo group is very small with only 3 patients. And that, of course, means that the statistics isn't quite as solid as you would want for a bigger study, right? So it's really just a 1B study to understand also how some of these outcome measures work in this population. Some of the patients were at least partially wheelchair bound. So not everybody was able to do the 6-minute walk test, which will become important later on. So if you look at all the different symptoms that are covered by the QMG, the ones that scored the highest are indicated in orange and red, and the symptoms that are affected the least are indicated in green. So as you would expect from congenital myasthenia due to DOX7, they would have usually not a lot of problems with swallowing, speech, or grip, which are the symptoms on the right-hand side, which are most green, while they would have problems with lifting or holding their arms up, their head, and the legs, which are all the symptoms on the left-hand side that are mostly orange and red. They were also quite compromised in terms of their FVC, which is sort of in the middle with quite a large number of patients that scored very highly in this. So what were the results? In these graphs, you see the patients that had the MuSK agonist antibody indicated with the blue balls and the patients who received the placebo in the gray balls. And this is only for the period where patients received treatment for these 12 weeks with these 6 consecutive injections of the study drug, not any sort of follow-up data that's not available yet, which will obviously also be very interesting. And what you will see is that for these 3 parameters that I show here, with the arms and legs outstretched and the head lift, that both the placebo group and the MuSK agonist group, they both improved to some extent. So there's quite a bit of a placebo effect. Again, the placebo group was very small. But there seems to generally be a tendency of that the MuSK agonist did even better than the placebo. This becomes a bit more evident if you look at the 6-minute walk test. In the panel on the left, it's the total distance walked, and then on the right, taken with a sensor, the cadence, the steps taken per minute. And as I said before, not all patients were actually able to do the 6-minute walk test. It's only about half of the patients. But here you see a clear difference between the MuSK agonist treated patients as compared to the placebo patients. So there was, on average, after these 12 weeks, a more than 50-meter difference between the 2 groups, which for some other neuromuscular conditions you would consider as clinically meaningful. And there weren't any sort of safety signals that made us worry about this treatment. So patients were also interviewed after going through the study, and the majority said that they felt they had better mobility, they had improvement of symptoms, they felt overall quite happy and satisfied with participating in the trial. Of course, at that point, they did not know whether they were on placebo or on the drug, but as we know from the data, the majority was on the drug, right? And only 3 were on placebo. Anecdotally, one of my patients said that he feels that he is on holidays from his condition, so that he was able to do things that he was not able to do for many years, like carrying his shopping bag upstairs or keeping up with his friends and stuff like that. So positive indication that we are hopefully on the right track here. argenx does plan now a phase 3 trial, which they have announced and will hopefully start at sites both in North America and in Europe in 2026. They also have started programs in amyotrophic lateral sclerosis and spinal muscular atrophy phase 2 trials with the same compound, under the assumption that if you activate MuSK with this compound and you stabilize neuromuscular transmission and the synapse, that this would be of benefit for these two conditions as well. But there were no results released as far as I know. We, of course, wanted to know, is this just a treatment that works in DOX7? Well, we know for the DOX7 mice, we have some early indication it works in DOX7 patients, but do other patients with congenital myasthenia potentially also benefit from this treatment? So we have two other mouse models in the lab that we tested this in, and they were the agrin mice in the top panel, so they have a point mutation in the agrin gene itself, and COL-Q mice in the lower panel, so with mutation in the COL-Q gene. Both of these genotypes do not respond well to methadone in patients, so there is a need. So we wanted to find out. David Beeson's group has also checked out receptor deficiency mouse models with this compound, and not showing the data for this. Anyway, if we go for the agrin mice first, so the blue line is the control mouse that's not treated, and they do usually die by about 50 days of age. And in green is the wild type glutamate that obviously survives normally until the endpoint is reached. And on the right upper panel is the four-limb grip strengths, whereby the wild type mice in green clearly have more strength than the agrin mutated mice in blue. If you give them a MuSK agonist antibody, then that restores survival in the agrin deficient mice, and it also restores grip strength close to the levels of the wild type mice. So that's a pretty impressive rescue, similar to what we see in the DOX7 mice. In COL-Q mice, so this is the lower panel, COL-Q mice actually do survive similar to the wild type mice, so there isn't any expectation of a survival benefit from treating them. But on the right-hand side, you see that the COL-Q mice have quite a force deficit in the grip strength test as compared to the green wild type mice. And if you give them the MuSK agonist antibody, unfortunately, not much changes. So they stay as weak as the control treated mice. So what we can conclude, at least from the mice with these mutations, that maybe agrin is a genotype that would be amenable to MuSK agonist treatment, while COL-Q probably is not. So therefore, argenx is currently expanding their program to also include patients with agrin, MuSK, and LFP4 mutations. And they started again with running a natural history on these patients, because we do not know much how they respond in tests like the QMG or the 6-minute walk test. So in summary, just for this first 1B trial, and this data was first presented a couple of months ago at the Ottawa Neuromuscular Conference, is that there is a favorable safety profile, and that more results will be released once the follow-up period is completed, and that will probably tell us more how long-lasting the effect is in humans as compared to the mice, for instance. And further studies are already on the way to get started. So I come to my summaries, just a couple more slides. So as you've seen, CMS are clinically very variable and heterogeneous. There's some clues pointing towards the underlying genetic defect. Next generation sequencing continues to uncover new genetic causes of CMS and helps broadening the spectrum of inherited transmission disorders. And the detection of the genetic defect is important for the selection of the appropriate drug therapy. Modeling in cells and animals is critical to understand the role of disease genes, the impact of mutants, identify pathways and therapeutic targets, and to test therapeutic approaches. So what can you as clinicians do? Well, first of all, have a high level of suspicion for CMS. We do believe it's underdiagnosed. And then if you think clinically this is congenital myasthenia, then go for genetic testing. And if the first genetic test is negative, then don't give up. Maybe it's just genetic test that you're doing, and maybe you need another genetic test or another interpretation. And we're always happy to include patients in research, for instance, doing trio genomes on them. If you have questions about your patients with congenital myasthenia or unclear diagnosis, it's worthwhile to discuss those patients with people either in our neuromuscular junction group or send me an email. And importantly, also sign up your CMS patients to the EURO-NMD registry. So if your site is activated for the EURO-NMD registry, then it would be of very high importance to get your CMS patients signed up there so that they become visible, both in terms of understanding their prevalence, but also for recruiting into clinical trials. If you have CMS patients already diagnosed, particularly with these genotypes, then they may be eligible for the ongoing natural history study and for the planned phase 3 study. And if you're more interested also in participating in some of this research, including to the relation to neuromuscular junction, myasthenia, and congenital myasthenic syndromes, then you're very welcome to join the neuromuscular junction group at EURO-NMD. And that's my last slide. So I thank all the people who helped with this work and my group here on the frozen Rideau Canal earlier this year in January for ice skating. I thank my funders and, of course, my co-lead of the neuromuscular junction group, Dr. Lorenzo Maggi. Thank you for your attention.
Thank you, Hans, for this quite interesting and comprehensive description of the neuromuscular junction issues. We have already one question on our pipeline. It's Vivek Jain. You can unmute yourself, Vivek, if you want to voice it. Otherwise, I will read it from what you've written.
Thanks, Antonio. Professor, this was a very helpful, very useful talk for our future practice. The thing I struggle with is the salbutamol dose. Like, is there a milligram per kg per day maintenance dose and a dose we can go up to? Because pyridostigmine we know, but for salbutamol, it's not clear.
You are muted, Hans. You need to unmute yourself.
There we go. So salbutamol dosage. So the first thing I would say about salbutamol, obviously it's a traditional asthma medication, beta-2 sympathomimedicum, and it does have effects on the heart, so it can increase heart rate, for instance. So most patients with congenital myasthenia obviously don't have any heart problems, including the patient with DOX7. So therefore, this drug is relatively safe, but out of precaution, we recommend that you would do at least an ECG prior to starting salbutamol or albuterol or whatever it's called in your country. And then repeat it after you started the patient on salbutamol after about 3 months or so. The effect of the salbutamol is often or becomes often apparent after a few days, not maybe as immediate as the mastodon, but it often keeps getting better over several months. So even if you only have a partial benefit after a couple of weeks, you might just need to leave it a little bit more time to have maximum effect. So don't be discouraged by that. So in terms of your specific question about the dose, so it's a bit different for children as it is for adults. So for adults, I would usually go to 2 or 3 times 4 milligrams a day. And that is often then a dose that people are quite happy with and where their heart rate isn't sort of going up too much. So that's a dose that's most of the time well tolerated. If it's well tolerated and people feel they could try a little more, I think I have a few patients where I've went up to like 3 times 8 milligrams per day, which I'm not entirely sure it always gives additional benefit. Some patients do think it's a bit better, but I would definitely not go higher because otherwise there's more effects on the heart rate, and it definitely then does not give additional benefit. It rather sort of wears out than with these high doses.
And how does it work? So I think that was how does it work? Huh.
Yeah, that's a $100,000 question. So there's several lines of evidence that neuromuscular junctions do have beta-2 receptors, and that obviously these beta-2 sympathomimetics bind to them and activate cyclic GMP, and then through a second messenger sort of activate neuromuscular transmission. But what's exactly in between, that's still being studied both in cell and in animal models. And we're
Thanks.
testing
Thank
actually some drugs. There's newer forms of some sympathomimetica that are more potent, and we're testing those in the lab, whether they would be better than the sort of relatively old salbutamol.
Okay, so at the moment there is no hand raised or questions, and so I'm going to keep the salbutamol road while people think about their questions. So
Can I ask?
yes.
So the case number 4, the Noonan syndrome, the photograph was showing more of a distal weakness. So do they have a slow channel myasthenia, the Noonan's patient?
No, they had generalized fatigable weakness. So
Okay.
the more specific distal weakness is something that we more frequently observe in slow channel congenital myasthenic syndromes. That's correct, but and occasionally in some other forms, but not in these Noonan cases, I would say.
Sure.
So Magdalena Łukaszewska, you can unmute yourself and put your question live if you want.
Yeah. Question is, does the trial included patients with AGRIN mutations? So the trial that I showed with the 16 patients, the 1B trial, that did only include patients with DOX7 mutations, not with AGRIN mutations. And the current natural history study that's already open for recruitment, that does include also patients with AGRIN mutations. And we will see once the protocol is made publicly available for the upcoming phase 3 trials, what the verdict is there, what exact patients will be included in that trial. So that's not publicly available yet.
Okay, so I don't know, Magdalena, She probably is satisfied with the answer. So I would go on to my provocative question. So why do these upcoming phase 3 trials do not have a salbutamol arm?
Oh, okay. I should have said that all the patients, I think it was on my demographics slide, are already on salbutamol and kept their dose the same because it was felt that this is standard of practice and that we would not want to have people come off their salbutamol. So everything that I showed was on top of whatever
Salbutamol.
benefit people had from their salbutamol.
And is there any trial demonstrating the efficacy of salbutamol alone before?
So we're trying to figure this out in the mice. What's the added benefit and what comes from salbutamol and how do they potentially interact in some ways?
But there is no human trial demonstrating the efficacy of salbutamol.
There are case series. So there's a good publication by David Beeson's group in Oxford that in a sort of case control study or a larger group of patients did show the clear benefit of salbutamol. So it's not a double-blind sort of placebo-controlled trial that has been done for salbutamol, but I think the sort of standard of care would include these beta sympathomimetica. They're not always easily available in each country, which sort of makes it more difficult. For instance, in Canada, we don't have easy access to salbutamol.
Mm-hmm.
Hello, I will ask a question for Magdalena because probably I'm better speak English than her. She has a AGRN mutation, and the question is, should she try with salbutamol or ephedrine with this mutation?
Mm-hmm. Yeah, so obviously I'm not in a position to give exact therapeutic advice on a webinar like this one here. This should be done by your doctor. But certainly patients that have genetically proven congenital myasthenia based on pathogenic agrin mutations may benefit from salbutamol. So I have a few patients with agrin that were treated with salbutamol that had some benefit, and we have published some of these observations because agrin mutations are very rare. The difficulty with agrin is twofold. One is it's a fairly large gene, so it has a lot of variants, and some of these variants may not be pathogenic. And if they're rare, then it's very difficult to say, well, this is disease causing or this is not. So that's number one. And the second, agrin has additional functions to what I've described. So some patients with agrin mutations do actually have a different clinical presentation. They don't have a classical congenital myasthenia. Some have more a motor neuron disease like phenotype, or some have even more of a myopathy type phenotype. And in those cases, I doubt that they would respond in the same way to the treatments that we give for congenital myasthenia. But I think for your friend, I would recommend to talk to their neuromuscular specialist about it.
Okay, thank you very much.
You're welcome.
So that's the good advice, I agree. And regarding the call that you done for the people to enter their patients into the registry of EURO-NMD, I would like to announce that from 2026, we expect to be able to receive patients from non-participating sites of the EURO-NMD registry. So people who, although they are not members of the network, they want to contribute patients. We are currently finalizing the legal framework to accept those patients. So yeah, so it's another news for people listening to us today. I think we've reached our end time and we've answered all the questions. Thank you very much, Hans. It was, as always, a pleasure listening to you, and I'm sure that the many attendants today will learn immensely with what you've explained, and we'll keep in touch in other webinars, I'm sure, to update on this in the future. Thank you.
Thanks so much, Antonio.
Please,
Bye-bye.
everybody participating with your feedback, the link is on the chat if you want to go directly to the form. Thank you. Bye-bye.